Hi, everyone, and welcome back to Grand Rounds. My name's Casey. I'm the nurse practitioner here taking care of our patient today. And let's get started. Our patient today is an 18-year-old female diagnosed with impetigo after being assessed and finding multiple honey-colored crusted lesions spreading across the face and arms, causing mild itching but no pain or fever, and this episode has been ongoing for at least 1 week. This patient has no allergies or recent trauma noted to the skin. She is an otherwise healthy female. Cephalexin or Keflex is a first generation cephalosporin antibiotic. I chose this as our first line antibiotic because of the patient's multiple lesions. This method is preferred over a topical due to there being a widespread infection. Oral therapies are able to treat a more vast area than topicals. It also covers MSSA and group A streptococcus. It inhibits bacterial cell wall synthesis, binds to the penicillin binding proteins or the PBPs, and causes bacterial cell lysis, otherwise known as it being bactericidal. Keflex is orally bioavailable by approximately 90%. Its peak plasma concentration lasts about an hour. It's widely distributed into the skin and the soft tissues. It has minimal metabolism, and it is eliminated primarily unchanged by the kidneys. It has a half-life of about 1 hour, which is longer with those who are renally impaired. It is time-dependent bactericidal, and its best efficacy is when the serum concentrations remain above the organism's MIC throughout the dosing interval. Mupirocin 2% ointment is a topical antibiotic which treats a localized disease or when a patient only has a few lesions. That is not the case for our patient. However, it could be a good second line treatment or a treatment in combination with an oral treatment. This does inhibit protein synthesis, a tRNA synthetase, and prevents bacterial protein from growing. This ointment minimally absorbs through intact skin. It metabolizes to inactivate monic acid. If it is absorbed, it's excreted renally. It is variostatic at low concentrations and bactericidal at high concentrations. Other second line MRSA alternatives are doxycycline, TMP SMX, and clindamycin. And those can be used if the patient has an allergy or other issues with the prescribed medication previously tried. Prescribed is cephalexin, 500 milligram capsules. Take 1 capsule by mouth every 6 hours for 7 days. Dispense 28 capsules with 0 refills. Drug interactions may increase INR when given with warfarin. Metformin concentrations may increase this slightly as well. Live bacterial vaccines may be less effective during this treatment. Food interactions may be taken with food. Actually, it should be encouraged to be taken with food so that way GI upset doesn't occur as often. No significant food restrictions, though, are noted. Common adverse effects are nausea, diarrhea, abdominal discomfort, headaches, vaginal candidiasis. Serious adverse effects, however, are allergic reaction or anaphylaxis, C. diff, And Steven-Johnson syndrome, although that may be rare, it is a full body reaction with rash and systemic symptoms as well. And those things should definitely be monitored for. So, good pharmacological treatment would be to wash your lesions daily with soap and warm water. Remove any crusts gently before applying any medication, so that way the medication's actually able to get in. You're going to keep lesions clean and covered if they are draining. Wash hands frequently. Avoid any scratching, trim fingernails. Avoid sharing of towels, washcloths, clothing, or any razors. Want to wash your bedding frequently, especially pillowcases, any clothing, and that should all be washed in hot water. Avoid close contact until 24 hours after antibiotic treatment or therapy has begun. Patients should be educated to complete the entire antibiotic course. So, this patient is being prescribed a 7-day course of antibiotics. They should complete all 7 days, not just stop when they're feeling better or when the rash goes away. Improvement should begin within 2 to 3 days. Continue taking the medication even if the lesions do improve. Take with food to avoid stomach upset. Report any other rashes, hives, facial swelling, or difficulty breathing immediately, as these could be signs of an allergic reaction. Seek medical attention if the lesions worsen, spread, or a fever develops. Return if no improvement is seen after 72 hours. Continue with good hand hygiene to reduce the spread to family members or those within close contact. Continue to monitor for improvement within the 48 to 72 hours. Resolution of crusting and erythema should also be monitored for, because you want to make sure that this is going to go away. Development of fever or cellulitis to watch for other infection. Allergic reactions such as anaphylaxis should be monitored for. Severe diarrhea is suggestive of C. diff, and renal functioning issues is significant due to kidney disease um, warnings in this patient. Yeah, for this patient. Also, routine labs um, are not required in healthy patients. However, if patients do have renal issues, you could draw labs in order to ensure patient safety as well. Thank you so much for joining Grand Rounds today. If you have any questions or want to look deeper into any of the topics covered today, these are the sources used in order to create this presentation. Thank you for your time, and I'm open to any comments.